Hello, and welcome to Lyme Carditis, More Than Blocked Beats. The learning objectives are listed here. I'm Dr. Elizabeth Maloney. I wrote and narrate this program. I have no financial conflicts to declare. Off-label use of approved drugs will be discussed. Let's consider this case. The patient is a 50-year-old gentleman who went camping in an area highly endemic for multiple black-legged tick pathogens. Soon after returning home, he developed fevers, chills, and a headache. Although the fever and chills slowly resolved, the headache became worse and he developed night sweats. He presented with this finding on day 11. What's the most likely disease for this gentleman's constellation of symptoms and signs? And what disease stage would it be? This patient clearly has disseminated Lyme disease, which can produce a host of problems. The major ones are listed and depicted here. Our knowledge of dissemination dynamics is limited. For example, early dissemination to the CNS has been documented, but many CNS presentations appear much later. Prolonged latency is not uncommon in Lyme disease. Whether it's attributable to the infecting pathogen, the host response, or a combination of factors is unclear. The original collection of symptoms and signs often expands to involve multiple body systems, yet this expansion does not occur in a predictable fashion. What might explain this? It's possible that universal dissemination is followed by periods of disease latency that are tissue pathogen specific. Alternatively, there may be periods of spirochetemia that originate from a sequestered Borrelia burgdorferi population. This patient also had this ECG tracing. Can you identify his rhythm? Looking closely at the tracing, you can see that there are no P waves, and the QRS complexes occur at irregular intervals, which is consistent with atrial fibrillation. Although the bradycardia is concerning in this setting, the patient is a lifelong athlete and typically has a pulse in the 50s. Here's a question to consider. In addition to his multiple erythema migrans, does this patient also have Lyme carditis? The answer to that question depends on one's perspective. For CDC reporting purposes, this patient does not have Lyme carditis. That's because the CDC surveillance case definition of Lyme carditis only applies to patients who have second or third degree AV block and positive two-tier serology. But from the pathophysiologic perspective, this is indeed Lyme carditis. Borrelia burgdorferi can infect any or all layers of the heart. AV block is thought to be the most common cardiac abnormality. Yet cases of atrial fibrillation associated with Lyme disease have also been reported. Given the circumstances, the new onset of atrial fibrillation in an otherwise healthy adult who has concurrent manifestations of disseminated Lyme disease, it appears that the two are related rather than coincidental. Thus, this rhythm is evidence of Lyme carditis. Generally speaking, cardiac manifestations of Lyme disease are due to an exaggerated immune response to B. burgdorferi in the involved tissues. The photo on the left shows the typical perivascular roadmap pattern of interstitial infiltrates. These infiltrates are made up of T cells, plasma cells, and macrophages. The two photos on the right show rare bacteria within cardiac tissue. The next several slides examine the pathophysiology specific to different cardiac tissues. Conduction abnormalities are the most commonly recognized manifestation of Lyme carditis, so we'll start there. Inflammation near the SA node can lead to atrial fibrillation or flutter, sinus pauses, and supraventricular tachycardia. This tracing depicts atrial fibrillation. Involvement of the AV node can produce first degree, second degree, or third degree block. Here are the representative tracings. In first degree block, all of the atrial impulses make it through the AV node, but conduction is slowed, producing a widened PR interval. In second degree block, not all of the atrial impulses make it through. In third degree or complete heart block, none of the impulses get through. The patient's survival is dependent on ventricular escape beats. There could also be conduction abnormalities at the His bundle or the bundle branches. Aberrant conduction can be entirely asymptomatic, but it frequently produces these sorts of symptoms and signs. In the case of Lyme carditis, the first recognizable symptom may be sudden death. A 2013 MMWR report by CDC researchers discussed several cases of sudden death in young adults. Lyme myocarditis may produce myocardial dysfunction that is either global or localized. The severity varies from patient to patient. This is primarily an acute manifestation of the infection. Depending on the severity of the dysfunction, patients will present with any or all of these symptoms and findings. While most patients will respond to appropriate antibiotic therapy, not all will obtain a complete recovery. The evaluation for myocardial dysfunction includes these studies. ECG findings include ST elevation or low voltage QRS complexes. You may see cardiomegaly, pulmonary congestion, and/or pulmonary effusions on chest X-ray. Echocardiograms may document left ventricular dilatation, reduced ejection fraction, and wall motion abnormalities. Enhanced cardiac MRIs may demonstrate localized tissue injury, changes in ventricular wall thickness, left ventricular dilatation, and reduced ejection fraction. This table compares Lyme endocarditis to endocarditis secondary to other bacteria. Unlike the other bacterial causes, Lyme carditis is not typically associated with pronounced fevers, chills, or night sweats. Petechia and splinter hemorrhages have not been reported for Lyme endocarditis. The most commonly reported symptoms and signs are fatigue, dyspnea, and a new or worsening murmur. Because there may be an associated conduction abnormality, the ECG in Lyme endocarditis may be abnormal. Valvular vegetations, common in cases of endocarditis due to other bacteria, have not been mentioned in clinical reports of Lyme carditis. The inflammation associated with Lyme pericarditis can prevent the normal gliding movement between the two pericardial layers. Friction leads to inspiratory chest pain and pericardial rubs. Patients may feel short of breath and be tachycardic and tachypnic. When pericarditis produces a large pericardial effusion, left ventricular filling can be restricted. Patients may be lightheaded, hypotensive, and have distant heart tones. Brune documented a case of cardiac tamponade due to Lyme carditis. Effusions distort the cardiac silhouette on chest X-ray. Diffuse ST elevations can be seen on ECG. Echocardiogram is the definitive test for pericarditis, and it can detect an effusion, measure it, and guide pericardiocentesis. Myocardial dysfunction due to Lyme disease isn't always acute. The potential link between Lyme and dilated cardiomyopathy continues to be debated. This paper provides strong evidence of an association, if not a direct cause and effect relationship. Of the 110 patients evaluated for unexplained dilated cardiomyopathy, 20% had a cardiac biopsy which was PCR positive for Borrelia burgdorferi sensu-lato species. Despite this direct evidence of infection, only 36% of these patients had positive two-tier serology. The study protocol administered ceftriaxone for 21 days. At the end of the 12-month observation period, 23% had normal LV function, 72% had improved function, while 5% were unchanged. The epidemiologic findings of Lyme carditis are definition dependent. This table summarizes the literature review of Lyme carditis and compares the findings for all types of carditis versus only those cases where Lyme disease produced third-degree AV block. Not surprisingly, the incidence of all types is 4 to 10 times greater than third-degree block alone. Lyme carditis is more common in men than women, particularly with regard to third-degree block. The median age of carditis patients is younger than the median age of all Lyme disease patients. It is especially interesting to note that less than half of the patients with third-degree block have a preceding or concurrent erythema migrans rash. It's important not to assume that patients will be seropositive on presentation or subsequently seroconvert. It's equally important to recognize that progression from second degree to complete AV block can occur quite suddenly. Less is known about pediatric Lyme carditis. In this paper by Costello, 16% of patients who were hospitalized with disseminated Lyme disease had either abnormal ECGs, pericarditis, or myocardial dysfunction. 7% had second-degree AV block, third-degree block occurred in 2%. Myocardial dysfunction was noted in 2%, and 3 children developed cardiogenic shock. This table depicts the likelihood of carditis based on clinical parameters. A second group of researchers looked at the association between Lyme meningitis and Lyme carditis. In order to meet the author's definition of carditis, patients had to demonstrate either AV block, STT wave changes, or a prolonged QTC interval on their ECG. 1/3 of the patients met that requirement. Of the children that had an echocardiogram, none had demonstrable LV dysfunction. In this cohort, 5 or more days of fever was associated with a 55% probability of carditis. Children 13 years of age and older had a 58% probability, and those who satisfied both conditions had an 83% probability of Lyme disease. Getting back to our patient, he was diagnosed with Lyme disease, and his new atrial fibrillation was thought to be unrelated. Given the previous content, do you agree? He was prescribed doxycycline 100 milligrams twice daily, a probiotic, and grapefruit seed extract. The plan also called for him to begin cefuroxime a week or 2 down the road. With respect to his atrial fibrillation, he was started on aspirin and an outpatient workup was begun. He returned 3 days later. Although his fever had resolved, he actually felt worse. He noted the recent onset of pain and stiffness in his right knee and exertional shortness of breath. His vital signs demonstrated that he was still in atrial fibrillation, and while he was not hypotensive, his blood pressure was lower than what was typical for him. Heart tones were normal and his lungs were clear. The right knee had a small effusion. ECG now showed atrial fibrillation with a third-degree block. His diagnoses now included the underlying Lyme disease, plus Lyme arthritis and Lyme carditis. The atrial fibrillation was still considered to be an unrelated problem. A cardiologist was scheduled to be on site in a few hours, so the patient was instructed to come back at that time. An outpatient infectious disease consult was arranged for the following day. This is his follow-up ECG, showing the absence of P waves and regularly occurring junctional escape beats. While waiting to return for his cardiology appointment, the patient developed nausea and jaw pain and was brought to the local ER. He described being lightheaded, which wasn't surprising given his pulse was 35. ECG again demonstrated atrial fib with third-degree block. There were no acute ST changes. He was promptly transferred to a tertiary care hospital and begun on IV ceftriaxone for his Lyme disease. He was closely observed on a telemetry unit in order to quickly detect any signs necessitating the emergent placement of a temporary pacemaker, something he very much wanted to avoid. Although ceftriaxone typically resolves third-degree block fairly quickly, this was not the case for our gentleman. In fact, his bradycardia became more severe. On the 6th day of ceftriaxone therapy, it was decided to start methylprednisolone. 2 days later, his resting heart rate was higher and increased with activity. His atrial fibrillation continued. Ultimately, he underwent successful cardioversion after finishing his outpatient antibiotic therapy. And what was that therapy? The ceftriaxone 2 grams daily was continued for 30 days. He subsequently took a combination of doxycycline and cefuroxime for an additional 6 weeks. The grapefruit seed extract continued throughout the treatment period. I'll discuss the theoretical details behind this somewhat unorthodox regimen later in the presentation. Our patient received methylprednisolone because his AV block persisted long after the initiation of ceftriaxone therapy. The theory supporting the use of corticosteroids is this: inflammation around the AV node causes the node to malfunction, producing various degrees of block. Corticosteroids resolve the inflammation, allowing for the subsequent return to normal conduction. However, a review of the literature suggests that steroids do not hasten the resolution of AV block. Not only do they not help, there's a chance that steroids can increase the risk for arthritis and neuroborreliosis, particularly when started prior to antibiotics. It's important to remember that antibiotics are not antiseptics. Without a functioning immune system, they are unable to fully eradicate an infection. Therefore, the use of steroids in early Lyme disease can blunt the immune response, increasing the risk of treatment failure. The progression to third-degree block was viewed as being a natural progression of the inflammation around the patient's AV node. But might there be another cause? It's possible that the increase in AV node dysfunction was due to a Jarisch-Herxheimer-like reaction. Recall that the patient had been started on doxycycline prior to the onset of his third-degree block. Antibiotic destruction of B. burgdorferi releases lipoproteins which trigger a rise in inflammatory cytokines. These immune mediators subsequently lead to physiologic effects in local tissues. The possibility that the change in the patient's cardiac status reflected a Jarisch-Herxheimer reaction introduces another option for managing the situation. While under close in-hospital observations, antibiotics could be temporarily held in order to allow cytokine levels to fall. On resumption, there would be fewer bacteria to kill, and in theory, any subsequent Jarisch-Herxheimer reaction would be less pronounced. The advantage of this approach is that it avoids the long-term risks associated with corticosteroids. The disadvantage is that it temporarily delays antibiotic-assisted eradication of the infection and might allow for disease progression that may not have occurred had antibiotic therapy been continuous. When managing patients with Lyme disease, it's important to recall that black-legged ticks often harbor more than one pathogen and are thus able to simultaneously transmit multiple tick-borne diseases. This confounds the clinical picture in many ways. For example, a patient's carditis may be due to a different pathogen, such as Anaplasma phagocytophilum, or a combination of tick-borne infections may produce more severe clinical manifestations. When faced with a dramatic clinical problem, it's not unusual for other things to go unnoticed. It's quite possible that our patient also had babesiosis. He had complained of night sweats, and his admission labs documented a hemoglobin of 12.1 in conjunction with elevated liver enzymes. These values were not rechecked while he was in the hospital. At his 6-week follow-up visit, his hemoglobin was back to 15.1. A PCR for Babesia microti was also drawn. It was negative. Because self-limited Babesia infections are common, a negative PCR when he is well does not rule out the possibility that he had a babesiosis acutely, but was able to clear it on his own. The understanding of Lyme carditis is incomplete. Comparative therapeutic trials and long-term follow-up studies have not been done. Epidemiologic data suggests that males are at a higher risk for Lyme carditis, which raises questions regarding the role of gender and sex hormones in the disease. Important questions regarding disseminated infections and the potential for the involvement of persister populations and cell wall deficient forms of Borrelia burgdorferi need to be investigated. Although the details of persistent infection are beyond the scope of this presentation, It's worth noting that persistent infection has been well documented in animal models and human case reports. Several in vitro studies have documented that persister populations and cell wall deficient forms do not respond to commonly used single-agent regimens. Recall that our patient received an unusual treatment protocol. The ceftriaxone was continued for 30 days rather than stopping at the time of hospital discharge. This was a purposeful decision in response to the use of methylprednisolone. The subsequent switch to oral doxycycline and the addition of cefuroxime and grapefruit seed extract were done to address the potential of persisters and cell wall deficient forms. Interestingly, this combination of medications is similar to the therapeutic combinations identified by Fang and colleagues at Johns Hopkins. These are the important clinical take-home points. 1. Lyme carditis can be fatal, so it's important to maintain a high index of suspicion. And when you do encounter it, consider the potential for other tick-borne diseases. 2. Serologic testing, both at the time of presentation and in the post-convalescent period, can produce unexpected results. Patients are frequently seronegative on presentation. Some will remain so. In others, the antibody response fades quickly, and these become seronegative. Some patients may only mount an IgM response. Bottom line, serology cannot be used to rule out the possibility of Lyme carditis. 3. Not all patients with Lyme disease require a baseline ECG, but it seems prudent to obtain them in young adult males with disseminated disease, patients with cardiorespiratory symptoms, and children 10 years of age and older who have either been diagnosed with Lyme meningitis or who have disseminated disease and arthralgia. The spectrum of Lyme carditis is wide and disease severity is variable. Therefore, it stands to reason that management decisions depend on the specifics of a given case. Patients should be hospitalized if they present with first-degree block in a prolonged PR interval, second or third-degree block, atrial fibrillation with prolonged and/or frequent sinus pauses, severe left ventricular dysfunction, or severe valvular dysfunction. Patients with first-degree block, uncomplicated pericarditis, mild cardiorespiratory symptoms, and normal valve function can be treated as outpatients. Inpatient therapy generally relies on IV ceftriaxone, which is typically changed to oral doxycycline at the time of discharge. In the absence of contraindications, outpatient therapy generally relies on doxycycline because it covers other tick-borne diseases that may be present. Amoxicillin and cefuroxime may also be used. Pediatric doses are also listed here as well. The duration of antibiotic therapy is generally 21 to 28 days. Probiotics should be prescribed to reduce the risk of antibiotic-associated diarrhea and C. difficile infections. Whether or not one should routinely address the possibility of persister populations and cell wall deficient forms remains unclear. Thank you for participating in this module, Lyme carditis, more than blocked beats.